All right. Hello, everyone, and welcome to our Nursing Expert webinar. We're excited to bring this great group together today and share a lot of useful experience and information with you. I just have a few housekeeping items to go through before we get started. Audio panels have been granted to everyone in attendance today, as we encourage you to ask questions and engage with our presenters throughout the webinar. With this, however, we ask that you please mute yourself when you're not speaking to reduce any potential background noise. If you prefer to submit any of your comments or questions in writing, please utilize the Q&A box or the chat function, and I'll be happy to facilitate those during the presentation on your behalf. If at any time you're experiencing technical difficulties, please contact me within the chat function. And now that those items are out of the way, and without further ado, let me introduce Pat Dilley, our Director of Clinical Information Systems at Harris On Point and our resident AcuityPlus expert to get us started. Pat?
Hello, good day to everyone. And it is our pleasure to be your host for this very informative AcuityPlus webinar. Let us never consider ourselves finished nurses. We must be learning all our lives. That is a quote from the first nurse, Florence Nightingale, as we celebrate Nurses Month. And I think it's an appropriate quote to get us started with our webinar. Next slide. So I'd like to introduce Kathy Matson, Nursing Administrator at Mayo Clinic in Arizona, and Walker Schlunt, AcuityPlus Productivity Coordinator at Northeast Georgia Medical Center. Kathy is going to get us started with her presentation. So Kathy, I'm going to turn it over to you.
Thank you, Pat, and thank you, Karen. So my name is Kathy Matson. I am a nurse administrator at Mayo Clinic in Arizona, and I oversee resources, so that obviously includes staffing our units and the issues that we all struggle with when we talk about staffing, which is how do we have enough nurses in the moment to take care of the patients as they present. Now that was a huge concern, obviously, this past year during the pandemic. And I'm going to talk a little bit about that and how AcuityPlus helped us with that, but also just in general how AcuityPlus helps you meet your organizational goals, including the goal many of us have is to either get magnet status or retain magnet status. Next slide, please. So just a little background, Mayo Clinic in Arizona is currently a 297-bed facility, acute care hospital, which will soon be, in January of 2023, a 404-bed hospital, as we add a 100-bed tower. Construction is going on currently. It's multi-specialty integrated group practice. We have a large collaborative triad relationship. We are a physician-led organization. However, every physician is supported and their practice is supported by an operations administrator and a nurse administrator. So these are salaried physicians. They work for Mayo Clinic only. We focus on serious and complex illnesses. At this point, currently, we only service adults or individuals over the age of 16. We do not have a pediatric or obstetric service. And we are magnet status. We were awarded in 2018 with 4 exemplars, and we are preparing for our next recertification on that. Next slide, please. So that's kind of who we are. And my objectives today are to help all of us understand how AcuityPlus supports organizational goals, meeting the staffing needs for safe patient care, and meeting our budgetary requirements. We'll also discuss a little bit how AcuityPlus supports an organization's magnet journey, which will be important for any of you who are on that journey currently. And then articulate the benefits of AcuityPlus in developing a safe staffing model. Next slide, please. So the one thing I do want to point out just at the outset is there are many patient classification systems out there, some EMR based. The thing of importance with AcuityPlus is that it's an evidence-based system. So having used this system for many years now, more than 12, I hate to admit that, one of the things I've appreciated is the research and development that goes into not just validating the base of the system, the foundational elements, but also revalidating over time, and the opportunity to participate in different research projects that both validate the system, but also validate what we see as changing patient needs over the years. There's evidence out there that talks about patient classification systems and the fact that they should and are, for the most part, evidence-based. However, some of your EMR systems that say their patient classification is still a subjective click by the nurse to say, I think my patient is this level of care. So I would just caution you that if you're looking at systems or evaluating systems, that you make sure you look for ones that are based in research. They have evidence to support how the acuity is derived for the patients and how your staffing needs are identified. Next slide, please. One of the things that AcuityPlus contributes to our organizational strategies is it unites clinical nurses, unit leadership, and nurse executives in this four-pronged approach to staffing. So it allows us to forecast what we're going to need. It allows us to look at our staffing from both a retrospective and prospective basis. It allows us to reformat our scheduling plans to meet the needs of the patient when we look at trends, and it helps us to improve our staffing models. Next slide, please. So there are differences in staffing models, and I just want to speak to those quickly. So this is really about AcuityPlus versus an hours per patient day model of staffing. So remember that many organizations do staffing based on a projection of patient days and observation days. And they base that on a standard hours per patient day. Now, what that hours per patient day does is it assumes that every patient requires the same amount of nursing care and intervention. When you begin to budget using hours per patient day, you're doing volume-based staffing. You're saying, this is how many patient days I'm going to have. And in current hospital environments, that includes both inpatient and observation patients that are in your hospital beds, but it just assumes that all of those patients require the same level of care from the nurse, the same amount of intervention, and have the same needs. And you use that to estimate what your budget is going to be for the coming year. Acuity-based staffing, however, really gives you a more actual picture of your patient needs. Staffing is recommended based on a set of classifications that are derived from the identified patient needs for nursing care. And this currently, the system we're using today under AcuityPlus is transparent. So it actually comes from the nurse's documentation of care and then looks back on some historical information about those individual patients. From that, the patient's type is determined and there's recommendations made for staffing both in the moment and for future shifts. So you can look at your staffing recommendations at any time in the system as the system is integrating information from the medical record on a kind of seamless background effort. This also gives you some historical trends on the type of patients that are on a unit, so that, and the associated workload measures of those patients. So let's say, for example, you're going to introduce a new service on a unit. Let's say you have a general med surg unit and you decide that you are going to take that unit and repurpose it for cardiovascular patients. So the majority of your cardiology patients. You can look back at trends of patient types for your current cardiovascular unit and apply those measures, building your new background parameters for your new unit. So it's really a good opportunity to look at what type of care are you delivering and how are you meeting the patient needs. So I think that's an important piece that AcuityPlus provides to us. And then annually, as you're looking at the historical use of your beds over a year's time, you may identify that a certain cohort of patients is suddenly requiring more care than what you had anticipated. So they could be that you have practice growth, I think of our own organization where we saw large growth in our neurosurgical practice in 1 year, where we had to go into the unit that housed those patients and really look at whether or not our parameters were correct for that unit based on the different types of patients we were seeing and what their needs were going to be. Next slide, please. And then let's talk about Magnet, because Magnet is a significant goal for most healthcare organizations. And Magnet is based on a foundation of nurse-driven decision-making. And I pulled out the 2 standards that really speak to this from a staffing perspective. When Magnet comes to your facility, they want to see an example with evidence of a time when clinical nurses collaborated with a nurse administrator to evaluate data in order to address an identified unit-level staffing need. We do this daily in my hospital, where the unit leaders, which are clinical nurses, meet with the house supervisors, and we import data to a worksheet that talks about what their recommended and actual staffing is, so that we can use that data to decide whether or not we need to add staff to that unit, or perhaps it's time to float staff from that unit. They're overstaffed, which is the unusual circumstance, I'll just say that. But it's an opportunity for us, and when Magnet was here, we showed them, they actually attended one of these meetings so they could see how we use the data from AcuityPlus to manage our unit level staffing on a day-to-day and shift-to-shift basis. And then when a nurse collaborates with nurse administrators to evaluate data in order to meet an operational need. I'm going to use the pandemic as one of the best examples of this. In Arizona, we had a large surge of patients, every hospital did. At one point, our hospital, 297 beds, had 145 patients with COVID in our hospital. We decided we would have to create cohort units for these patients. And when we did that, we went in and we looked at AcuityPlus and we set appropriate parameters for those cohort units so that we could staff to meet the patient care needs that we anticipated. These patients required really stringent monitoring, especially from the respiratory side. And we had them in every one of our care environments. We had them in med-surg, we had them on telemetry, progressive care, and in the ICU. So AcuityPlus helped us figure out how to staff those units with the appropriate staffing to care for these really complex and unusual patients we hadn't really dealt with in the past, and certainly not in the numbers that we were appreciating them here in Arizona during the pandemic. Next slide, please. So AcuityPlus really gives the voice of the bedside nurse to the staffing conversation. In some older versions, and some may be using this still, I don't really know that answer, we did manual classification where the nurse would check off the different categories of care required by the patient using some 21 indicators that were known to show a difference in care needs. But there were some inaccuracies in that system, and really due to more the subjective decision making. And there were gaps in classification due to the nurse's inability to complete due to her workload. So sometimes we would have unclassified patients. Other times we would see the classification that was checked out by the nurse didn't really match the nursing documentation for the care that they provided. And sometimes that overclassified a patient and sometimes it underclassified a patient. But again, manual classification was, our first methodology to try to capture what the needs of the patient were. We now have moved to transparent classification, which is derived from the historical patient needs, translated from nurse documentation of patient care, and then it removes those subjective determinations, which has been really a blessing for us. We find that our classification accuracy is truly reflective of the patients on our units. I have very few concerns brought to me that the classification or the recommended staffing isn't appropriate for what their patient needs are. So I think this transparent system has removed that kind of subjective piece, made it completely derived from the nurse's documentation of what they did for the patient. And our monitoring of this really clearly is to make sure that people are providing patient care as ordered or determined either through nurse decision-making or physician orders. So the transparency, I think, gives you another level of capability to use this data within the organization to drive change and to drive budgets. So I know Ken is going to speak about budgets later on, but I will tell you that once you remove a subjective classification model, the finance individuals, upper level executive management are more open to listening to your compelling case for why we need to perhaps increase FTEs on a particular unit or drive change to how we deliver care. The other really important piece of how we use AcuityPlus in Arizona, and I know this isn't used at all sites, is we use the staff forecasting tool. And this gives us insight into the next shift staffing needs. It allows for an assessment of the use of resources by giving us staffing recommendations based on what we already know about the patients we have and allowing us to forecast for the patients we know we're going to get. So, one of the problems I think in staffing we all have is how do you staff for what isn't on your unit yet? And so we have been able to make assessments of incoming patients, transfers that are going to arrive in our facility for the next shift, or likely admissions from our ED or our PACU, and we can assign them in the forecaster the average type patient for that unit. And that way we can predict some staffing to be able to care for those patients when they arrive on the unit and before there's any documentation to drive their acuity type. So staff forecasting has been extremely beneficial in providing us with a good staffing recommendation for our oncoming shift. Now we then compare that to our actual staffing, retrospectively to see how accurate we were in that forecast. That really is a way to help our unit level leaders understand how to forecast. What should you be preparing for? And really allow them to use their own critical thinking skills to drive what the staffing is going to be for the next shift on their unit. Next slide, please. So our staffing decisions here are made through staffing meetings with team leader input and currently available staff. Now, I'm going to go through each one of these, but I will say that team leader is a title we use here in Arizona. It is a clinical nurse. Team leaders are also capable of working at the bedside and often do, but they represent their unit in staffing decision-making on a daily and shift-by-shift basis. Next slide, please. So we meet 3 times a day to plan and adjust staffing as needed to meet our patient needs. Our meetings in Arizona are at 9:30 in the morning. They're at 4 p.m. in the afternoon and at 3:30 in the morning. All inpatient unit team leaders attend these. There's a representative from the emergency department, somebody from the procedural areas so that they can appreciate what impact our census may have. There's somebody from our PACU, respiratory therapy, and then department leadership and security will attend ad hoc if we are in a considerable overflow situation. If we have 45 patients in overflow beds, then we want leaders at the table too to help figure out how we're going to mitigate this issue and staff all these patients that we have that are in non-traditional care areas. Security will attend when we have some security issues in the building or in the surrounding environment of the hospital, just to keep us informed of what's happening outside of our doors. Next slide, please. The team leader is the key in this one, because here's what the team leader carries with them as they come to the staffing meeting. They've received report from their bedside nurses on all their patient statuses. They know what their current census is. They know how to use critical thinking to determine whether or not a particular patient is going to, they may know that a patient is declining on their unit. And so they may be a type 3 now, but it looks like they may advance to be a type 4 patient, or perhaps may need to be transferred to a higher level of care. And so they need to bring that information to the staffing meetings. And then they have the use of the staffing forecaster to compare what the forecasted staffing for the next shift should be and what they have on their list of available staff to work. In these meetings, we do float our staff to like units, And so it may be that Unit A has 2 extra nurses and Unit B needs 2 nurses, and then we would then facilitate floating 2 nurses from Unit A to Unit B based on what the team leaders report to us are the needs of their unit and what the staffing forecaster tells us about what our recommended staffing should be. Next slide, please. And then available staff. Really, it's important to match staff to patient care needs. We can't send the rehab nurse to the ICU. And I'll tell you, it's not really workable to send the ICU nurse to a med-surg unit. The care differences are so great that nurses are not comfortable in those changing environments. So matching staff to patient care needs is an extremely important piece of staffing decisions. Responding to changing practice environment is also important. If we know that we have 4 or 5 potential transfers to higher levels of care, we need to respond to that by making sure we have competent and qualified nurses for those higher level of care environments to assume care of those patients once they move. We don't want to be trying to manage them, let's say on a med-surg unit, when they need to go to progressive care or ICU. So we need to make sure that we're responding to those potential changes and having staff available to accept those patients. And then it allows us, AcuityPlus allows us to look at trending for future staffing needs, both based on census trends, this unit looks full all the time, and based on patient types. So you may have a particular unit that has a subspecialty like cardiovascular or neurosurgery, and you want to see what your trends are for census. You also want to see what the care model is. What if you have new physicians, they may be trying new treatments that require a different level of nurse intervention at the bedside. So we want to make sure that we're watching both of those issues, census trends and the patient type. Next slide, please. And then here's some benefits of AcuityPlus. As you all know, you can't hire and onboard staff quickly to respond to year-to-year variances in the workload. I'm not sure what the hiring cadence is in your organizations, but in this organization, we're fighting for staff among many hospitals in our metropolitan area. We believe we attract staff with our benefits and pay. However, you still have to appreciate what's the work environment. And it takes almost 150 days from the time you post a job till you get a nurse who's hired and ready to work. So you've got to have some look to the future in what you're doing. And AcuityPlus gives you that, as you can run trended reports. You can look back and try to see where your trends are taking you so that you can think about what you need to do for hiring. I'll tell you that I'm using this currently as we prepare to open this new 100-bed tower. As I look at where those subspecialty practices will be on what units in the new tower, I'm looking at our current AcuityPlus for where those patients are currently to see how we're going to staff those new beds. It's even more difficult to hire and onboard staff quickly when your actual workload varies from the planned workload. We learned this significantly in the pandemic. These patients required much more care than the general med-surg patient required, even if they were on med-surg. And so we had to scramble, as everybody did, to get staff. So we actually had almost 150 travelers here, travel nurses, to help us with our COVID pandemic patient care workload, both on the units as well as in some of the offshoot work places we stood up, like occupational health, to try to get everybody fitted for N95 masks and following up on workplace exposures, etc. So it's an important piece of being able to look forward, look back, and make decisions that meet the strategic plan of your organization. One of the things that nursing needs to own, this is paramount, we need to measure workload and we need to staff to workload. When we hear about burnout, when we hear about nurses who say they're overstaffed they're understaffed because they're looking at ratios. In our organization, our nurses do not look at ratios, they look at acuity. And it took us a couple of years to get to that culture and move away from a ratio staffing, because ratio, again, assumes every patient is the same and requires the same level of nursing care. but also nurses have to have the flexibility to make hiring and FTE decisions in response to the patient care needs, not responding to a ratio and not responding to an hours per patient day calculation, but really responding to what the patient care needs are for the patients you're bringing into your facility. AcuityPlus contributes to all of these efforts. It gives us the information we need to both look at how we're doing and see if we need to make changes. One of the efforts we went through a couple of years ago, I'm going to give you an example of how you can use AcuityPlus, is we had falls. Falls were a concern for us. So we made an effort that every time we had a fall on a patient, we looked at what the recommended to actual staffing was on that unit to make sure that we were staffing to workload and staffing to our recommendations to see if we had an issue with staffing effectiveness on any individual unit. We did not, but part of that, I think, is how we staff and the fact that we bring those staffing recommendations to the table. We talk about them, we measure them, we look at them, we trend them, and we respond to them. Next slide, please. This is my contact information. I'm certainly always willing to have conversations with people if they need more information about how we're using our patient classification system or some of the things we've discovered over time that are real benefits when you're going to the budgeting conversations or starting up new service lines. I think I will turn this back over now to Karen. I don't see any questions in the Q&A section.
Yep. Thank you so much, Kathy. A quick reminder to everyone to submit any questions you may have for Kathy or any of our other presenters in the Q&A or the chat boxes, and we can revisit them during our Q&A session in just a little bit. Next, I'd like to welcome Walker to talk about his Acuity journey.
Well, good afternoon, everyone. My name is Walker Schlett. I work for Northeast Georgia's Health System here in bright Gainesville, Georgia. Here in the southeast, it's kind of warm outside. It's nice. Go ahead and next slide. I came into this position in 2017 after transitioning out of the ER. I came to this organization as a charge nurse and opened their newest facility there in Brazelton. It's kind of interesting turning the lights on in a hospital for the very first time. But I transitioned out of that and took over this position as AcuityPlus coordinator in 2017, as well as picked up a few odds and end duties along the way. My nursing background mainly is in med-surg, critical care, and ER. I have worked at bedside in all three of those capacities, and it brought a lot of information to this role. And so that was probably why the position came to me so easily. So go ahead, next slide, please. Northeast Georgia Health System here based out of Gainesville consists of 4 different campuses with a total of 32 units on 1, 14 on the 3 and 2. We manage Acuity and track all sorts of things through AcuityPlus on all of these campuses. It is a major factor when we have finance meetings as well as budgetary meetings. It is tracked and reported on biweekly, basically on by pay period. The nursing leadership understands it and works with it, and we track it on a very strict basis. We are transparent for many of our units, which means that the information flows from our EMR, which is Epic, directly into AcuityPlus. A couple of our units are still working manual classifications, and but that continues to be a work in progress as we continue to try to transition them over to that direct from the EMR system. Next slide, please. This is just a few of our accomplishments here. We're pretty well known here in the Georgia area, but outside, not maybe so much. We do actually use DNV as our accreditation, which is a little bit different than Joint Commission. We've found that they've kind of maybe lead a different style of working with those times that it's not audited, but they come by and visit us and do site visits and stuff like that. So we've enjoyed working with them. Next slide. So our history with AcuityPlus goes way back, and I actually had Ken and Pat pull the data for me because it comes even perhaps before I was a thought. Northeast Georgia actually implemented AcuityPlus and its predecessors back in the 1980s. There is information from in the data books that actually comes from our system from the late 80s. which means it's been around for a long time. Now, it's not always been used exactly up to 100%, but we're slowly getting there, back there, you know, different years, different leadership is just how it worked. We transitioned from McKesson, in which we were transparent, to Epic in 2017 and kept that transparent classification system. Now, transparency is its own beast, if you will. It requires a big mapping table, and there's a lot of effort, a lot of work, a lot of teams put together to make sure that table was created and everybody kind of adhered to the ideas of what we were tracking for charting. Go ahead, next slide, please. Now, we all know we're in the middle of the end, maybe, of this pandemic. I kind of cross my fingers, right? But it has been a challenge for nursing staff across the country, across the world. It continues to be that way, and that was even before the pandemic. We were still having shortages and issues, and how could we provide safe care for our nurses in that kind of situation? And it comes down to a lot of things, like, you know, when it comes down to these ratios and the different people that are working on those sorts of things. Go ahead with the next slide. And I know, you know, for historical purposes, I'm sure this was something that she would have said, you know, in recognition of her work to greatly push forward our career, our path here, working with individuals and sick people. But it's been a challenge, even from then, I'm sure. And so one of the things that always comes down to this is, how do you make a good assignment? Go ahead to the next slide. And making the right assignment there's a lot of factors. We all know that. If you've been a nurse for any length of time, you understand that you're going to make great assignments where everybody's going to be happy with them, and you're going to make bad assignments where, you know, you underestimated one thing or another, and that comes from experience. You've got to learn this, and new nurses, new charge nurses, it's just part of the learning mechanism that comes. And sometimes there is no good answer. But with leadership and leader experience, you start to kind of gain that understanding of how to make a good balanced assignment based on the details you have. Now, one of the things can also happen, as you can expect, sometimes favoritism can come into it. You know, if you've got your best friend coming to work with you, then maybe that sometimes it can kind of seep into your thought pattern, and we've got to be careful with that. Now, acuity, I would say that most nurses would understand some form of basic acuity. They'd say, okay, that one's sicker because they're always in the bed and they need 3 people to help them get up out of bed and to roll or to turn or whatever. Acuity is a factor that we all understand, but we don't really know all the details, and we don't necessarily have all the information on a piece of paper in front of us. As always, there's this limited resource factor. Not everybody has a nurse for every patient. That just doesn't exist. And so the leaders and the charges and people making assignments have to look at those limited resources and kind of stretch their pieces, stretch their people a little further sometimes, and that's hard. And that comes, you know, back to that leadership. You have to know what team members can be stretched a little bit. Also, it falls down to your staff experience. I know a lot of places, and it's been over the course of time, that a lot of places have very green nursing staff on night shift because seniority. You know, the position opens up on days. The senior nurse on night says, "Okay, I'm done with this night thing. I want to have a real life," and they transition away. They transition up into day shift, and so now on night shift, you're hiring a lot of green people, and learn in time. They'll get their experience, but it does take time to build that up. And then, of course, you've got to have the flexibility. When you're making those assignments, it's critical to be able to understand how you can move things in a very quick manner. You know, it could be everything from you know, this patient doesn't want a male nurse, or this patient has an issue that requires a different kind of you know, maybe a Spanish-speaking nurse, something like that. Flexibility is important, and you have to understand what your team can do and provide in order to make a really good assignment. Next slide. Now, I say all this because I'm bringing forth the idea of this AcuityPlus. AcuityPlus, a lot of places and a lot of different applications can just spit out a number, and they give you this arbitrary number that they've decided out of all these different pieces, this is the number, and it could be based on doctor's orders. That I've seen that. I've seen it based off of, you know, ESI is kind of similar like that, in that you pick a different number of factors, and that's the number they get. You know, how many resources are they going to need, and that gives you a number. But AcuityPlus goes much, much further, and it's much more than just, you know, your hour probation day getting spit out of a computer and say, this is what you should have. It is actually based on the care provided and documented. Now, documented, remember, as nurses, if you haven't documented, you didn't do it. That was part of the deal. I'm sure they hit you over the head in nursing school just like they did me. You've got to document everything you do. Now, the value of that is that this system, AcuityPlus, can grab that information out of your EMR and really provide you with some real detailed information. And one of the great things about this AcuityPlus is it's constantly changing over the years. There's decades of data that back up these classifications, how they do that, and each different kind of patient population, for lack of a better term, and I say that perinatal has their own classification system because, as you know, little babies may have a little bit different things going on than adults, and behavioral health absolutely different than just your traditional inpatient med-surg ICU kind of patient. And so this data collects over time, and we start to build new classifications, and we track new patterns that are coming to us through healthcare, even internationally, because this AcuityPlus is used all over the world. Next slide, please. So I'll tell a quick real life story about why this is so critical to some of these things. My director came in one morning and he hands me this piece of paper and he says, I need you to look at this, and I want you to do a little audit. I want you to dig into what happened here. And he explained to me that there was a serious safety event on one of our floors, and that the nurse had said that they were absolutely overloaded and they really needed help, and essentially people ignored them. This person, was adamant that they asked for help, and of course then it becomes this, well, he said, she said, back and forth, and there was a lot of emotions, as you can expect with safety, serious safety events. People want to blame somebody. People want to, jump on the person, and of course it's at night, so now you've got that extra factor. Anyways, my director was smart enough, and I'm saying that in a bad way. My director understood the tools available and brought this to me, and we were able to take this information and start to really deep dive into what may have happened or what really did happen, at least from an objectively acuity-based place. Next slide, please. So I took that sheet, and you remember it has all these words and scribbles and all that stuff, but I wanted to get down and really understand what nurse had what patients. And I went ahead and did an audit within our Epic system as well. AcuityPlus actually has the ability to go ahead and show me who was on false protocols as well, but I double-checked it just to make sure we captured all of them. And so you can see these are just the room numbers, and these are the patients. Right off the bat, you can see that both A and F, I mean, even if you just didn't know anything at all, you could see that each of them had false protocol patients for all 6 of their patients. There was actually a nurse there, G, that only had 4 patients. That's a little odd, right? When other people have 6, maybe there was a little bit of balance. Maybe they were waiting for the first admission. Hard to know right off the bat, because one of the factors when it comes to this, a staffing sheet, it's a snapshot in time. It's what it is right this second when I sign this piece of paper. And in 10 minutes, it may be completely different and change. Because new admissions, new discharges, et cetera. So, but right off the bat, we can already see that there's this issue with maybe some false protocols, because if you're on a false protocol, it means you are unstable. You have a risk for falling and possibly hurting yourself. So, next slide, please. So I went ahead, and this is one of the really big factors of AcuityPlus, is you can actually pull in this information historically. One of the problems sometimes that comes up is if I wasn't there in the time, I don't know what was really going on. Well, I can actually go back and using the documentation through Epic or your EMR, and then using AcuityPlus as well, I can dig down and really figure out what sort of details were going on and what the acuity level was at any one point in time. That makes it a big factor, because one of the things you can't do very well is necessarily look back in time with an EMR, unless you dig into every single chart and really do a deep dive. Now, so we'll just go quickly down this. RNB, I'll explain this. So recommended, REC, is the recommended number of nursing hours needed to take care of the patients that they were assigned. And this is over, you as a nurse are a 12-hour person. You came in at 7 a.m., you're going to leave at 7 p.m., or you came in at 7 p.m., you're going to leave at 7 a.m. So, AcuityPlus will actually tell you, based on the acuity, based on what the details that have been charted in your EMR, what's going on with the patient, this is the number of nursing hours you should have devoted to your patients. So RMB, 9.9, little under, considering you're there for 12 hours, but maybe again, that's just how it worked at the very beginning of the shift. 11.8, that's pretty good. 12, a little over, but not bad. Another 12, 13.94. Now that's starting to stretch, right? I mean, how do you cram almost 14 nursing hours into a 12-hour shift? You don't. It's tough. Maybe you're the one that called out and got a little bit of extra help to come help you do a task or start an IV or things like that, and you were the one that was kind of calling for that assistance. 10.23, kind of low, considering you were there for 12 hours. We could have maybe rearranged that a little bit. And then 11.66, pretty well expected. That's the number of hours we would expect, essentially, for a nurse to work during a 12-hour shift. Now, hit that button for me, please, Karen. So we were talking about the RN. Remember, we had the serious safety event. We were digging into the audit. This is that RN. This is the assignment load she was given at night, and already right off the bat, you can see it's big red on purpose, of course, but 19.95 hours. 20 hours was expected of this nurse to cram into 12. I don't know about you. I'm not Superman. Maybe you are. I don't know. But I can't get 20 hours into a 12-hour day. I don't have physically enough. I cannot do it. There's no matter running, I go, skipping the bathrooms, lunches, dinners. I can't get 20 hours into a 12-hour day. It doesn't work. And so right off the bat, this was very blaring in my, to me during this audit. Go ahead. Next slide, please. So the results of the audit, right? This is that 1995 that we saw. Objectively, it didn't matter if this nurse asked for help or not. This nurse was overloaded. I mean, there's no doubt about it. The documentation proved it. The details in the charts proved it. And in the end, this may, now of course, serious safety events can be prevented sometimes, but when you go to this extent and this person, asked for help or didn't ask for help, I believe they did. I have no reason to doubt they didn't. So I believe they asked for help and didn't get it. And maybe, I can't go so far as to say that would have prevented the fall, because falls are inevitable. We all work in healthcare, falls happen, but it could have prevented possibly this fall. By balancing that out, by moving some patients, by even understanding that these patients were an overload for this one nurse, could have prevented this fall. And one of the big factors that came from this is twofold. One, this nurse there was a manager involved, there was a director involved, a lot of different people, because serious safety events are what they are, that really wanted this person essentially, punished and fired. Okay, we'll go that far. And it was almost to this unfair level, because it was before they even had all the information. It was before they had the details about how this person had asked for help and really wanted to reassign, or can we get some extra body to help me do this? And all these factors started to come out. And by being able to show them these details, these objective, not subjective, objective details that this person truly was overloaded way more than anybody else on their floor, the staff and the leadership started to come around and understand that piece, have that compassion about maybe they truly were overloaded. Maybe they really, really were. I mean, they didn't just say it, they were. And so it led to this fair treatment, because that's one of the factors around here that we like to encourage in our area, is just that everybody gets treated fairly. We don't go based off emotion. We don't go based on, different factors like that, or he doesn't like you or she doesn't like you, therefore, we get write-ups and things like that. It's based on objective data, and that's what AcuityPlus let us have. It gave us that tool. And so, go ahead to the next slide, please. And so what came of this was the rise of using this tool more. As was shown previously, this tool can be used often and even in a live sequence. At this point in our organization, we're not necessarily using that, and of course that comes with some challenges. There's a lot of mistrust because of technology. People aren't, if I can't see it, if the nurse before me didn't hand it off to me, did it really get in the chart right? Did it really pull into AcuityPlus correctly? Well, there's a mistrust of kind of that technology piece. Documentation, the nurses would, and this is kind of the discussion, is if you don't have a standard documentation strategy, you have to make sure that what you're going to chart, it matters. You can't just tell your nurses chart what you want. That's not good, and there's a little bit of a mistrust of that. Of course, there's that old school idea of being kind of proud as a charge nurse. I know I had it at one point. My gut will be always better than anything your computer ever spits out at me. And so you've got to kind of get over that. Accountability is a piece if everybody uses the tool, it's great. But if you don't use it, then it starts to be that, one person uses it and one person doesn't. That's kind of an accountability issue. The other one is if you're accountable by using this tool, it does away with a lot of that favoritism or other issues or reverse favoritism, however that works. And so next slide, please. So we've already kind of talked about it, but the benefits really are there's no more guessing. This is objective data. This is from the chart. This is from, even days before, depending on how you set it up. So there isn't a guess. This patient is this level of acuity. They need this many resources. Therefore, you should not put this patient and that patient all together because that's going to lead to some issues. One of the benefits is as charges use it and begin to use it often, it becomes just kind of an easy way to do your setup because in the back of your mind you've got that extra little piece that kind of gives you a little bit of a confidence booster to know that you did do a balanced one. It isn't just based off of your gut anymore. And then just throw that in there. PCTs, there's a way to do this with patient care techs or patient care assistants, whatever you call them, that can use this as well. And so they found when we started using it on them as well, or using it for them, that they liked it better because it was no longer you've got A hall and you've got B hall, regardless of what's on A or B. It's now you have these rooms and you have these rooms, and it's more balanced. And actually, the patients get better care that way. And so that was the whole focus of the whole thing, was that we wanted the best care for our patients in everything we did. So I think that's how I close out this presentation, and I hand it back over to Karen.
Thank you so much, Walker. And again, if you have any additional questions for Walker or Kathy, please submit them in the Q&A or chat boxes, and we'll revisit them during the Q&A session. Next up, we have Ken Colbert, our Senior Research Analyst, here to discuss budgeting techniques with AcuityPlus. Ken?
Okay, thank you, Karen. And thank you, Walker and Kathy, for your great presentations. So again, I'm Ken Colbert. I'm a research analyst with Harris AcuityPlus, and I'm coming to you today from the beautiful farmland of Michigan. So next slide, please. So, Walker talked about using acuity-based assignments. Kathy touched on a lot of uses for acuity, talking about acuity-based staffing versus HPPD-based staffing. And I want to expand a little bit on that and talk about acuity-based or hours per patient day-based budgeting. And I know our time is going a little short, so Karen did signal to me that we do have a couple questions. So I'm going to go quick today and just spend about 5 minutes or 4 minutes talking about acuity-based budgeting versus HPPD-based budgeting. Next slide, please. Okay, considerations when budgeting. I'll start at the bottom. I think a lot of folks, when they budget, they look at, what's happened in the past, and then, add to that some prediction of, what's changing, what's trending, what's going to happen in the future. Another thing, obviously, when you're looking at budgeting for individual units, you want to look at what kind of support factors are available, some level of staff experience, and look at some environmental factors. Another tool can be benchmarking, whether that can be NDNQI, the University Consortium. There's a lot of other benchmarking products out there. But I think, anyone who's worked in nursing for a while or in nurse leadership, you end up hearing, when you talk about benchmarking, you hear about the WAD syndrome, the We Are Different syndrome. So when you're using hours per patient day and trying to benchmark, they'll say, well, our acuity, my unit has some step down beds, or, we have sicker patients, so we don't compare these HPPD to these other benchmarking databases, so we get the We Are Different syndrome. So as you go to the next slide, we can see some of the differences between budgeting by acuity, or as we have in the title here, hours per workload versus HPPD, hours per patient day. They both build upon a basic unit. Hours per workload will build upon hours associated with one unit of workload, where the HPPD obviously builds upon the care hours for one patient occupying one bed for one day. Where they start differentiating from each other is budgeting by acuity accounts for patient mix. So it gives you that more precise measurement than HPPD. And it can start addressing and combating that WAD, the WAD syndrome, that we are different, because now everyone is being measured by their acuity or by their units of workload. HPPD is more the historical way a lot of nurse staff has been budgeted, and it's kind of the common language used by administrators in finance, but it really does not consider the varying care needs of different patients. Next slide, please. Okay, essentially, acuity-based budgets, we take acuity, turn that into workload, and then the factor becomes hours per unit of workload. So a little bit different than just census and hours per patient day. We have the extra step of turning acuity into workload, then having our staffing target that's based on hours per workload. The nice thing about it, though, is that acuity and hours per workload can translate back into HPPD, so we have a common language with finance and administrators. Next slide, please. Okay, we heard a little bit about COVID, both in Walker's and Kathy's presentation today, but I think this is fairly vivid, for folks that were budgeting by hours patient day. What we saw back in March of 2020 was in a lot of institutions, census started dropping quite dramatically. So for our average AcuityPlus client, and from our database, we saw it drop from about 500 to down to about 300. So census were going down. So if people just said we're going to readjust our budget based on hours per patient day, there would have been some issues, because at the same time census was going down, we can see exactly what was going on with their acuity. The patients left in hospitals tend to be quite a bit sicker. So that HPPD that started the budget was no longer valid because we had a much different patient population. So this is a case where if you were using HPPD to budget, you could have found yourself in deep doo-doo with your nurses. Next slide, please. Okay, just a quick example of how the different budgeting is done with HPPD. It's started with expected census. You have a budgeted hours per patient day, and that translates into shifts for 24 hours. The example here is based on 8-hour shifts. We know a lot of units operate in a 12-hour per shift world. Once you have your shifts that you need per day, obviously to turn that into a budget, we need to account for weekends, need to account for benefits, and that we see if we want to staff, in that example with med surge, if we want to staff 34 shifts a day, we end up needing about 54 FTEs or people to do that. And obviously most budgets then translate into what kind of people you need. So here we have some targets for RN and our PCAs, and we get our required FTEs. And if we look at our next example, for acuity-based budgeting, you see the same type of mathematics, but there's a couple of different steps, extra steps really, is we have a census, we have a projected overall acuity, and that can be based on historic trends, what you expect, or if you're operating, a new unit or new area, we have databases that can say, I'm opening a new oncology unit, here's what kind of acuities I can expect. So from census and acuity, we get workload, and then our staffing translation number is what we call target hours per workload unit, our target hours per unit of workload, however you want to say it, and then we get our shifts per 24 hours. And again, we have to turn required number of shifts into required number of people and do the extra math. So a quick comparison in the next slide of these budgets. If we looked at acuity-based versus HPPD-based, one of the things that can work against units in the HPPD world is sometimes those budgeted hours per patient day are dictated, by finance. So all med-surg units or all general units might get an HPPD of 9 hours, and all critical care might get an HPPD of 18. Of course, we know, the folks in administration and finance understand nursing intricately. They know about the churn and, how sick patients are. So they always get those HPPD hours correct, but maybe not always in the real world. So in this example, what we can see is using using a finer method of using acuity. What we see in that med-surg unit is we look at that total FTE line, that unit using that general target of 9 hours patient day might actually give that unit more FTEs than they need. Whereas in our ICU example, looking at 18 hours per patient day as a target, we end up getting on shifts per 24 hours 40.5 versus about 44 shifts per 24 hours. And I think, believe me, that would be that difference of about 3.5 positions, would severely be noticed by your nurses and affect their well-being, the retention, and so forth. So, a lot of times, how you budget and what you end up staffing, really has a lot of repercussions down the road. So using the best tools and the most predictive tools and most accurate tools is what we'd recommend. And I'm going to turn this back over to Karen, and I believe we have just a couple minutes to get some quick questions. So thank you.
Thanks, Ken. There's been such a lot of great information shared this afternoon. Now we'd like to open it up for our Q&A session, so please feel free to unmute yourselves and engage with any of the presenters you've heard today. We also have many members of the AcuityPlus team on the line to answer any questions that you may have as well. And I'll be monitoring the Q&A and chat boxes if you'd prefer to submit any of your comments or questions that way. And I will go ahead and kick it off with something from the chat. This question is for Kathy. How did you add COVID workload to the AcuityPlus classification?
So one of the things we did when we started to see our COVID patients is we made sure that we adjusted what our parameters were for the units that were going to have the cohort units. So an example is when you set your parameters, you're setting what your target is for hours per workload index. We knew that that needed to change with those patients. So we went into the system and we changed parameters to appreciate what those patients were going to require, our estimated requirement for care, based upon what we knew about the illness itself and what patients were needing. So by doing that, then the system will calculate correctly what your recommended staffing should be and how you should be able to staff to meet the patient needs.
Great. Thank you, Kathy. The next question is for Walker. What was your biggest challenge in transitioning from assignments based on census to workload-based assignments?
It's a good question. I mean, the challenge is really, it comes down to the idea that the workload is kind of that measure of acuity. It takes into account, the patient and what the things they need to be taken care of. And it's not just that hours per patient day like Ken was talking about. I think one of the biggest challenges was really kind of getting maybe finance on board so that they could see that piece and having that ability to transition and show that, just because you can throw me a number and say this is your hours per patient day, maybe I can give you a better number. And also balancing and communicating between nursing and finance that we could really hone and really focus our care in this way, and both sides would essentially be happier.
Great. And I have a follow-on to that question. Has using acuity-based assignments improved nurse turnover and overall nursing satisfaction?
I would say that for the units that do use it on a regular basis, they have seen improvements on their satisfaction. They also have seen the fact that another piece that we started to do was use this for new charge nurses specifically to see what and because acuity-based can be that whole historical piece, we could during their conversations and during like the training, because we do some training with our new charge nurses. You could take their assignment and see, how did it work out? How did it look like? And also they have this tool so that they could benefit with that. It's an ongoing project, as you can imagine, and of course with COVID and the different things that are going on with turnover, it's kind of hard to just say right off the bat that yes, this is improving it or not. But from what I'm understanding from the managers that are using it and the chargers that are using it on a regular basis, they have seen a better satisfaction with it.
Great. Thanks, Walker. Next question is for Kathy. How long did it take nursing to embrace acuity-based staffing, and what did nursing leadership do to help them transition?
Well, we've been doing it for a long time, so I think Walker touched on this in his presentation. Leadership had to be all in on this. We had to sell it to the staff that this was going to be a better way to staff their units. And when we were moving to this model, we actually showed them what their staffing looked like using hours per patient day. And then in our test system, we ran some models of what it would look like using AcuityPlus. And we actually could demonstrate to them that their staffing was more aligned to what they believed their staffing should be with the AcuityPlus numbers and not with the hours per patient day numbers. So that went a long way to winning people over. But then you have to overcome the trust in the system piece. And I'll tell you how we did that. We had the units own their data. So I don't, and my AcuityPlus coordinator, we don't go to a unit and say, we don't think you're doing this right. We go to the unit and say, help us understand why. And then whatever our issue is when we're looking at their data. And the units actually own it. And they tell us how this is working, what's happening. And then that gives us an opportunity to re-educate on the system. Or we may identify that there's a gap in the system and we need to go back with AcuityPlus and figure that out. So I think over time, and with use, people have come to actually trust the system, and they trust that, when we moved to transparency, they were very concerned that we wouldn't accurately reflect their acuities. And knowing that it's based on documentation, it put responsibility on the clinical nurses at the bedside to do the documentation and actually reflect their work. So I do think our trust has been just in the use of the system and the fact that leadership, executive leadership, and finance all speak about acuity. They do not speak about ratios or hours per patient day.
Thank you, Kathy. So it looks like we're just coming to the end of our time together today. So I want to take a moment to say that we very much appreciate you taking the time out of your busy schedule to join us. Also, I want to remind you that you'll be receiving the recording from today's session along with contact information. So please feel free to revisit today's presentation. We know it was jam-packed with a lot of information. Also, share it with colleagues and don't hesitate to reach out to us with any questions or feedback that you may have. Thank you again, everyone, and I hope you have a great rest of the day.